Welcome back to the Explainer series, everyone. I'm your host, Harshal, and today we're tackling a topic that has fundamentally transformed how we deliver and, just as importantly, how we bill for patient care. We're diving right into the complex and, let's be honest, often confusing funnel of remote care coding. We're going to unpack the exact codes, time thresholds, and the strict compliance rules you need to know for telehealth and digital evaluation and management, or EM services. So, let's get into it.
Here is our roadmap for today. We'll start with the telehealth landscape, then cover digital e-visits explained, audio-only telephone care, virtual check-ins and images, and finally, compliance and bundling rules.
Section 1. The telehealth landscape, setting the stage.
Okay, so what actually counts as telehealth for CMS? At its core, a true synchronous telehealth visit requires live, two-way, interactive audio and video. When you meet all the regulatory and documentation requirements, CMS actually recognizes these remote encounters as completely equivalent to an in-person office visit. This means you report them using your standard office and outpatient EM codes, specifically 99202 through 99215. And depending on the payer, you're going to apply specific modifiers like modifier 95 for synchronous audio-video or modifier 93 if it's an audio-only telemedicine encounter that's explicitly covered by that payer.
CMS basically breaks remote care down into a few distinct buckets. You've got synchronous live audio-video over on one side, and then on the other you have audio-only telephone encounters, asynchronous store and forward care where patient data is sent over for later review, and brief virtual check-ins.
The absolutely critical distinction here is drawing a line between a full synchronous audio-video visit and what we call communication technology-based services, or CTBS. While telehealth acts just like a standard office visit, CTBS covers all those non-face-to-face, digital, or brief communications, and that is exactly what we are going to unpack next.
Section 2. Digital e-visits explained, patient-initiated portals. Let's look at our first specific bucket of CTBS, patient-initiated digital portals, commonly known as e-visits. According to CPT guidelines, for an encounter to even qualify for the 99421 through 99423 code set, it has to be patient-initiated. It's strictly for established patients using a secure platform like your patient portal. But here is the real kicker. You aren't billing for just a single one-off message. You are billing for a cumulative time frame that you calculate over a full 7-day period. You absolutely must anchor these time thresholds to memory. 5 to 10 cumulative minutes gets you a 99421. 11 to 20 minutes bumps you up to 99422, and 21 minutes or more is billed as 99423. Remember, this is the total time spent evaluating, assessing, and managing that patient digitally over those 7 days. Now, you might be wondering what happens when these patient-initiated digital services are performed by clinical staff or non-physicians who can't independently report standard EM codes, like, say, a physical therapist or a specialized nurse. Well, in those cases, you cannot use the 99421 series. Instead, you'll use their exact counterparts, codes 99424 through 99426 or G261 through G263, depending on the payer. The time thresholds are identically structured, but this makes sure you're correctly identifying the provider type to the payer.
Section 3. Audio-only telephone care, when video isn't possible.
This bucket is for when video just isn't possible, but the physician or qualified healthcare professional, the QHP, still needs to have a direct medical discussion with an established patient. Just like the e-visits we just looked at, telephone E&M codes are strictly time-based. However, these are based on the direct medical discussion time on that specific phone call, ranging from 5 up to 30 minutes. 99441 covers 5 to 10 minutes. 99442 covers 11 to 20 minutes. And 99443 maxes out at 21 to 30 minutes of direct discussion.
But hold on, before you drop those codes on a claim, you really need to understand the guardrails. First up, you absolutely must obtain and document patient consent for these services. Second, you cannot bill these telephone codes if the call originates from a related E&M visit that occurred within the previous 7 days. Why? Well, because that follow-up call is considered bundled right into the previous visit's payment. Similarly, you can't bill this code if the phone call results in an in-person or full telehealth visit within 24 hours or even the very next available appointment. In that scenario, the time and work of the phone call just roll right into that upcoming visit.
Section 4. Virtual check-ins and images, quick triage.
Moving to the narrowest end of our remote care funnel, let's look at quick triage mechanisms. For Medicare and many commercial payers who adopt CMS rules, we rely on two distinct HCPCS codes designed for very brief, specific technology-based interactions. You need to know the difference between G2012 and G2010.
Let's kick it off with G2012. This is your go-to for a quick virtual check-in. It's defined as a brief 5 to 10 minute technology-based communication by a physician or QHP. The entire purpose of this call is to determine the medical necessity of an in-person visit. Basically, the patient reaches out and the provider does a quick check-in to decide, hey, do you need to come into the office or can we manage this simply over the phone? But again, if this check-in leads to an office visit within 24 hours, you do not bill G2012. It just bundles into the visit.
On the flip side, we have G2010. This is used specifically for asynchronous care, which you might know as store and forward. This is when an established patient takes a picture of a weird rash or records a quick video of a symptom and sends it through a secure portal for the provider to review. The provider evaluates the image and follows up with the patient. That entire interaction is captured neatly under G2010.
Section 5. Compliance and Bundling Rules. Keeping the auditors away.
Okay, to wrap up this explainer, we absolutely must review the strict guardrails that keep your billing practices audit-proof. The biggest risk with digital coding isn't necessarily picking the wrong code, it's double billing for time you've already been paid for. Pay close attention to frequency limits. A lot of payers restrict how often these codes can be billed in a given time frame. For e-visits, if a separately reported EM visit occurs within 7 days of the digital inquiry being initiated, that digital work gets incorporated into the EM visit. You can't bill both. Also, if the digital inquiry is related to a surgical procedure and happens during the postoperative global period, it is completely bundled into the surgical package. You simply cannot report it separately. You also have to ensure there's a really clear distinction in your documentation between time spent on prolonged services or active care management versus this digital communication time. I want to leave you with a direct quote right from the CPT guidelines. It is basically the golden rule of time-based EM coding. No time may be counted twice when reporting more than one EM service. Whether you're doing chronic care management, transitional care, or billing a standard office visit on the exact same day, the specific minutes you attribute to a digital e-visit or a telephone call must be completely carved out and distinct from any other billed time. No double dipping.
And that leads us to the ultimate challenge for your practice today. Do you actually have the proper EHR documentation templates in place to accurately track cumulative digital time over a 7-day period? Without a reliable system to log when that 7-day clock starts, what specific activities the provider performed, and exactly how many minutes were spent on those digital tasks, these codes are going to be completely impossible to defend in an audit. Take the time to build those templates now.
That covers our deep dive into the fast-paced world of telehealth and digital EM coding. I really hope this explainer helps you capture the hard work your providers are doing remotely. Take a moment to ask yourself, is your practice leaving legitimate revenue on the table simply because of outdated documentation habits? Take control of your templates today. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.